We are going to transition to our panel next. So the speakers that you've heard from this morning are going to be here. We can ask questions, and then we have two additional guests as well. Barb Nakanishi is a certified diabetes educator, and we have a pharmacist as well, Dr. Summer Al Nabala, who is joining to be able to answer questions. So if the panelists want to come up and get comfortable here in the seats, I will go ahead and do another door prize while we're getting settled. And then we'll have about 15 or 20 minutes for question and answer. I'll have a microphone and I'll walk around and you guys can ask questions for the panel. I know it's a little bit warm in here. We have propped open all the doors to try and get a little better airflow. So hopefully it starts to cool down a little bit as we go. Before we kick into the panel, I will say one note. We want to be educational. We want to be informative. We want to be as helpful as possible. I'm sure all the care providers that are up here want to help you individually. We won't be able to answer necessarily individual, like personal medical conditions. So there may be a question that they defer and say, that's great. I can give you some general information, but follow up with your provider for that question. So keep that in mind. Again, we want to be helpful. We want to get education and information, but may not be able to give individual personal medical advice in this forum. Okay, I'm going to draw another ticket for another one of the baskets that has some treats, some goodies, and it has the InBody coupon in it. And if you stick around after the Q&A, our final door prize is we call them Big Red Lodges right behind the facility here. They are wonderful facilities that you can stay the night. So they're like hotel accommodations, but in a very peaceful, relaxing setting. So a lot of the presentation today has been about diabetes distress and maybe some of the stress that comes with it. So we want to treat one lucky winner to a night in the lodges, courtesy of McConnell Heart Health Center. So that will be our final prize for the after the panel. For the basket winner, last four digits, 3792. Okay, let me draw again. 3776. Okay, we got a winner in the back of the room. All right, so two of these speakers. You got to hear from them, but our two additional speakers, we're going to give them a moment to introduce themselves. So Barb, if you want to go first.
Hi, everyone. I'm Barb Nakanishi. I'm a dietitian and certified diabetes educator. I worked a long time in Southeast Ohio at Ohio Health O'Bleness, and then I moved here, so not too long, a few years ago. And I'm at the Delaware Health Center, so I'm at one of the McConnell Heart Health Center satellite locations. I love talking to people who have diabetes. I like helping reduce your distress and make your life better.
Hi everyone, my name is Summer Alnabali. I'm one of the pharmacists on the diabetes care team, so I see patients with an A1C greater than 9%. I call them on the phone, I help you guys adjust your medications, and then hopefully we can get your blood sugars down and your A1C to goal before your next doctor appointment, so I can kind of help get things done more efficiently. I went to Ohio State for pharmacy school a couple of years ago, and then I did my residency training at the Cincinnati VA where I was working with veterans, and now I'm back up here in Columbus, so thank you.
Okay, we'll kick it off. If you have a question, just throw up your hand and we'll walk around and get the microphone to you. Perfect.
Hi, everyone. Thank you for being here. I have a question about somebody mentioned about the importance of a diabetic bracelet. I have a son who's special needs. He won't have one on, but why is it so important to have an ID of a diabetic bracelet?
Well, in case of an emergency, so the paramedics know that diabetes is an issue, they can look for low blood sugar or other things. Do you want to say?
Yeah, I agree. we see patients get admitted to the hospital that come in on psychiatric holds, and there's actually nothing wrong with them psychiatrically. They are brought in because they have really high blood sugars or really low blood sugars, and so they're found down, and no one knows what to do. It's so that if the patient can't tell someone that they have diabetes, that there's a way to identify it.
So is there you're wondering if there's a solution if the child won't wear the bracelet? Some people get tattoos. That's the first thing that I thought of. What else is on, anything else is on your mind?
Is it just a bracelet that he won't wear? And I guess.
He's got a mind of a 3-year-old.
Yeah, so he might take it off. Is there any? Sometimes they, stamp, like the clothing stamps that you can see that identifies, a child at daycare, like this shirt belongs to. If you would stamp it, like on the inside of the shirt.
I like the stamp that you all use for the bingo. I think that I can get
Oh,
a
yeah.
stamp that says diabetic.
Yeah, yeah. I mean, a temporary tattoo even. Tattoo is one, but I've seen temporary tattoos too that patients will wear. They're like, I don't want it permanently, but I'm trying to think what else. Yeah, necklaces, jewelry is usually a popular thing, but those clothing stamps. He probably doesn't carry a cell phone with him, but they have there's health apps on this cell phone.
I need to wear one too. I didn't know how important that was.
Yeah,
Makes sense that-
yeah.
Yeah, thank you for being here, like my wife said. But what you said about not permanent tattoo brought my question. I just recently read an article about reversing diabetes and wanted to hear from your perspective if that is even realistic. The article claims that following like many of the recommendations, exercise, nutrition, etc., there is a chance within, let's say, a couple of years, reverse diabetes.
So type 2 diabetes, where you have a state of insulin resistance, you have those non-modifiable versus not modifiable risk factors. You can reverse diabetes. So, but once you have the diagnosis of type 2 diabetes, that A1C is 6.6, you have the diagnosis, so your body has the propensity to have that insulin resistance, but you're able to control it. So it's all about control. So it's type 2 diabetes controlled versus uncontrolled. If the A1C is less than 6.5, you're controlled. And you can do that with diet and exercise early on in the disease process.
So medication will always be necessary.
No, not medication, just lifestyle. So there are some patients that, like I said, they come to clinic and they do not want to be on medications. By the time they get to me, the A1C is pretty high, so we have a good conversation about medications. But if they're able to modify their lifestyle, they may not need those medications forever. Okay?
I heard the current term is diabetes in remission. What is it if you've had diabetes and your labs are normal without medication for, what is it, 3 months or 6 months? Now I can't remember the time frame. Somebody at the ADA decided this a few years ago that the best term might be remission. And you probably know this, but I think it's important to know that people who are 10 years out diagnosed with diabetes may not be able to say that they're in remission because they might need the medication. But does that make sense?
Yeah.
Okay. Anybody else?
Okay.
So I don't have a question, but I wanted to just direct this to the lady that was asking about the ID bracelets. There is a company that makes kid-friendly ID bracelets, and it's called Medical Alert. So you might want to go there. They have all different things other than bracelets. They have dog tags. They have stuff. I don't know how old your child is, but you can put on their sneakers. So it's called Medical Alert.
I wanted to add to that. the perspective on that. Like getting your kid involved in creating their bracelet could be a great motivator, right? So getting their favorite stickers, we're going to lay it all out. And we have your favorite action figure person, and let's make something. And then having that conversation of, we want you to wear this all the time, can get them motivated.
Hi there. I just wanted to also add that I'm the lady with the medical bracelet. I wear one. Stand up. I got mine off of Amazon, and I added like my four health challenges that I have, because I live alone and I'm not married. So if something happens to me or they find me unconscious or not aware, that they will know that, hey, I have asthma, hey, I'm anemic, and I am type 2 diabetes, and I have on there that I take insulin, that I have Singular for my asthma. So I have the challenge and the things that I use, and maybe if you can get your child to see that, it's for benefits. So if something happens, he won't have to, if he's ever alone or at school or whatever the case may be.
Great tips. Okay. Got another question here.
I had one doctor tell me that I was pre-diabetic. Then another doctor told me there is no such thing as pre-diabetes. So what's the real story?
That's a great question. Or borderline diabetes. I love that one too. So by definition, we have to talk in medical terms, and there has to be a universal medical language for us to talk physician to physician. And that's where the pre-diabetic term comes from. The technical definition is if your A1C goes above 5.7 to 6.5, you have prediabetes. I think there's some hedging sometimes where it's like, oh, it's high, but you don't have diabetes. You have borderline diabetes. By definition, an A1C of 5.7 to 6.5 is prediabetes.
Thank you. I have a two-part question. I wear a CGM, but I also prick my finger at least 3 times a day. So my question is, are there any other places you can prick besides your fingers? I mean, what is so sacred about fingers? And number 2, on your little graph, you show 140 as being maybe where your blood sugar might be before you eat. Is there something sacred about that? Because I might have to wait 8 hours for it to get below 140.
Oh, those are good questions. So with regards to where you should prick the finger, that's where you can kind of milk it. So, I mean, and that's where, the small capillaries are. Do you prick, I would say, try the sides of the finger? You do the sides? Okay. Yeah, because the finger pads, you're right. May I ask a question as to why you still check 3 times a day? Is it because you don't trust?
I don't trust my CGM.
Okay, yeah.
And like the current CGM I have right now is reading 30% off.
Yeah.
And I just don't trust it.
Yeah.
And I've been doing this you talk about burnout. I've been doing this forever.
For a long time, yeah.
Over 40 years.
Yeah.
And so that's why I do it. I just don't trust it.
There really, I mean, if you can, there was at one time a lancing device that would lance the forearm. Sometimes in the hospital we have to do the earlobe to milk when the fingertips aren't accurate and we're not able to get blood out of them. But it's just a matter of access to the capillary blood in the fingers. Sorry, I don't have a good answer for that. And your other question was, I'm sorry. 140. 140 is a landmark that you should land on before meals. Because, again, it's that universal language, but that's the goal. Before a meal, the sugar should be less than 140 if you're on treatment. And really, if you're, modifying your lifestyle, trying to control it with diet, that 140 is the recommendation across the board.
So I should wait until I'm under 140?
You don't have to. You should look at, that's your goal. It doesn't necessarily mean that you have to be there before you eat a meal. But ultimately, maybe some medication adjustments need to be made to get you to that goal.
How do you know when it's safe to reduce your medication?
I do think that again is patient dependent. For me, patients will come into clinic and they'll say, I'll say, what are your blood sugars running? What is your A1C like? Are you having low blood sugars? What are you doing with your lifestyle modifications? If you're on insulin and you're having all these low blood sugars overnight, it's time for us to cut back on some medication. So it's just looking at your goals and saying, have I met my goal blood sugars? Have I met my lifestyle modification goals? If you have and you feel like you're able to control things with those modifications, then you can start cutting back the insulin. I'm not saying, or insulin or other medication, I'm not saying stop it completely, but cut back. We usually start by, taking away one medication, giving it 3 months, seeing what the A1C can be. But it's very patient dependent.
What about those new testers that you put on your finger and it scans your finger? Are those accurate? Are they legit? Or is it too new of a technology?
I think it's too new of a technology. I'm sorry, I'm not even sure what brand that would be. Who makes it?
It came from, I don't know. I don't remember. It was a company in California, but it scans your finger so you don't have to prick. And I can't remember the name of it.
Is it Eversense?
Maybe.
No. So Eversense, it's a newer development. I will say that I do worry about that because there's nothing testing the interstitial fluid. I feel like there's a lot of things that would compromise that. Is there a barrier on the skin? Did you put lotion on the skin? What if your finger, I think that it's too much, too new of a technology to really be able to tell. Mm-hmm.
So one thing, this was great, by the way, but one thing that I'm surprised did not come up is the effect of alcohol, and not from a sugary perspective or anything like that. I feel like it's mixed, what I've heard. Mm-hmm. If somebody can kind of address that and what it does to your body versus, I don't know, and how it interacts. Thank you.
All right, I'll take it. Yeah. For alcohol, for me and my patients, alcohol is about safety. So alcohol, I say never treat if you're going to drink. Specifically, patients on insulin, your blood sugar will go up with some alcoholic drinks like beer or certain liquors, especially if they're mixed with the soda. It'll go up, but overnight when you sleep, alcohol gets, or during the day, I use overnight. 'Cause if you have a nightly drink, let's say, overnight, alcohol is metabolized by the liver, and then your liver makes sugar in the fasted state. So if your liver's busy metabolizing the alcohol, it's not going to make sugar, and you're at risk for a low blood sugar. So I worry about low blood sugar with alcohol use a lot in my patient population.
And then, if you're overweight to begin with and you're trying to manage your weight, you just need to think about the calories in the alcohol and how that's affecting your overall goals and your meal plan.
Hi, doctor. I have a question pertaining to medications, because I've heard that certain medications such as metformin is not necessarily good for African Americans who have diabetic 2 symptoms or higher. Have you heard of anything like that, or is it true? No. And how would you treat someone that has that kind of mentality of thinking if it's not true?
Yeah. So I would say that would be a myth. You are not excluded from treatment because you're African American. You can use metformin. Metformin is standard of care for patients with diabetes. Like I said, it's the only insulin sensitizer that we have, meaning it's the only thing that's going to make us more sensitive to the insulin we make or the insulin that you're given. It also, in the liver in the fasted state, makes sugar. So when your sugars go up, metformin helps to tell the liver not to make as much sugar. So you would be a candidate. I'm going to debunk that myth. I think metformin gets a bad rap because it's an old drug, and everyone's like, I've been on metformin for 20 years. Like, what's it doing? Some people really want off metformin for one reason or another. And then we work together and we say, okay, if your goal is really to get off metformin for some reason, or they had a family member or someone that had a complication from taking metformin, the biggest side effect is upset stomach. Some people just can't stomach it, and I completely understand that. I'm not going to make you take it, but it is a good medication to start with.
My sister takes, she's diabetic, but every prescription she gets, we can't make her take it, which we've always been pleased with because her medication always get recalled or so, there's always these stories behind it. How do you gauge around that?
In the farm, maybe you can,
Recalls?
Yeah.
I haven't had too many patients with issues with recalls. I mean, it comes and goes. Usually it's a particular batch that might not have been good. But I would say long term with a lot of the diabetes medications, I haven't seen too many recalls with them. Maybe, medications in other classes. And if there is a recall, your pharmacy usually reaches out to you pretty quickly. It could have just been a medication from a specific factory, so then they can replace it with a medication from a different factory, from a different manufacturer. It could have just been that maybe they didn't put enough drug in the tablet, or it could be that maybe there was some kind of contaminant. So there's various reasons that they might recall something. It's usually not a life or death situation. It's more so, overall being overly cautious, and that's usually why they recall something.
There was a lot of different slides that were talking about 2 hours after you eat. And GLP-1s are known for slowing digestion. So how does that change the 2-hour threshold?
Yeah. I guess the 2-hour threshold is more so you understand your sugar shouldn't be going over that 180 in general. You're right, GLP-1s do slow gastric emptying. So they make you feel fuller longer. That's how they work. But they're also going to tell your pancreas to make more insulin response to that food. So it will help to keep that postprandial, that 2-hour blood sugar down. You should. Some people, though, want to look at their 2-hour goal. That's why I included it in there. But really, you look at the pre-meal sugar.
2 hours is kind of like our cutoff. We don't want to look 10 minutes after you eat or half an hour after you eat, because definitely it's still going to be going up. But by 2 hours, we don't expect it to still be going up if your medications are right for you, if you're on the right doses. So that's kind of like our earliest cutoff.
You might talk to your doctor about an adjustment.
That's another question that I have, because I'd really like to see a specialist, because of other things I've got going on and other medications. And my primary care physician is more sports medicine. He's primary care. He's been taking care of me, but we agreed that maybe I should see an endocrinologist. But no endocrinologist will see me.
No?
I'm too healthy.
Oh, you're too healthy.
My last A1C was 6.3.
Oh.
So it's like, well, you don't need an endocrinologist. You're doing a fine job.
Okay. Yeah.
And we have resources here at the Heart Center as well that we could get you some information. Even meeting with like a diabetes educator, I think might be helpful if a specialist isn't. So we can get you some information. Yeah. Gotcha. Yeah. Okay, we are getting just past time. Do we have any final questions? Somebody that has a really burning question? Okay, this will be the last one.
I just wanted to ask about metformin. So if I'm on 2 insulins, should I continue taking metformin? And the physicians, my doctor retired, so I have a physician assistant. And I told her that I was going to go to what you do, is it
Endocrinologist, diabetes doctor, yeah.
So I told her I was going to do that, but she said she can do a lot of the same things that you do. To me, not really, but My question is, she's told me to take insulin in the morning, take the fast acting and the slow acting in the morning, and up it to 14, and then the blue, the one that's the fast acting, to make it 10, and then take 40 at night when I go to bed for the slow acting. So it seems like, okay, so when I was there a couple weeks ago, it was a 7.3. I got it down because last year it kind of got crazy, and so I'm working my way back down. So a couple weeks ago was a 7.3. And so my question is the method just to increase my insulin to get it to go down, or in addition to a better, making the right changes in diet and exercise? I started going back to the gym in February. So my question is, I feel like I'm not being told to do the right thing just to keep increasing my insulin to get down to a 6 or a 7?
I think it's really, patient dependent. I know you're going to kill me for saying that, but, treating to goals, there's a lot of factors that go into it, increasing and decreasing insulin doses. I would ask her to see an endocrinologist. We'd be happy to see you're on insulin, to talk about your medications and how they can be adjusted. And in pharmacy too, part of the program that you do is adjust, insulin doses and medications. They're a really, really good resource in the primary care realm to help patients with diabetes. So you could ask about that too. Mm-hmm.
And I was going to say, for my patients, like if they just had maybe a small bump in their sugars, I'll talk to them and I'll be like, do you want to make diet and lifestyle changes? Is there something that you can identify right now? Maybe you didn't have a good last 2 weeks. Maybe you were really busy. Maybe you were eating out more. We don't have to adjust your medication today. That's kind of the conversation that I have with them. So I talk to patients and I see, do you feel like there's things that you can change right now? Do you want to try making those changes before we increase the insulin? So it is definitely, because I meet with patients every week, every 2 weeks. So, I definitely like to have that conversation, and you can bring that up to your PA too and be like, can we hold off? Are my sugars okay? Can I try to do diet and lifestyle changes? So that's always, you always have two options. It doesn't always have to be just increase the medication.
All right. Well, thank you to the panel and to everyone that had questions. I thought that was really good time. So thank you.